Assalamu alaikum. Today's case is right radical nephrectomy, laparoscopic, for a tumor on the posterior surface of the kidney. This part of the procedure is included because there was a difficulty mobilizing the liver. As we all know, that liver has to be mobilized if it is attached to the structures here and there, so that liver can be lifted and retracted in order to properly deal with the kidney. Here one can see that there are adhesions of colon, most probably the left-sided colon or the transverse colon to the liver, which is impeding our way to the kidney. In the meanwhile, there was a small prick in the liver by the bipolar forceps, which started bleeding. However, it is a magnified view. That's why the bleeding seems to be more, but it is not significant, and it can stop spontaneously. So we keep on dissecting and separating the colon from the inferior surface of the liver. Care must be taken not to injure the part of the colon which we cannot see, as we all know that laparoscopic view is a two-dimensional view, so one can miss some delicacies, and this can lead to various complications. Here nicely it has been mobilized, and the wall of the colon is beautifully intact. So moving forward towards mobilization of this part of the liver for retraction, so we go a little more further, and slowly and gradually things become easier. However, initially, after placing the visual port, it was a surprise for us, and we had to make a plan and a plan as well to proceed with. So triangular ligament is mobilized, and the mobilization of the liver is enough now. So we place a port in the epigastrium, retracting the colon medially so that it doesn't get in the way of the trocar and get injured. And then we place a self-retaining Alice's forceps below the liver, which can be attached to the diaphragm, and see no. So we reposition it so that good space is available for dissection. And now we can see that the kidney is visible. And now we mobilize the hepatic flexure and the ascending colon medially, as these are the routine steps of simple nephrectomy, radical nephrectomy, partial nephrectomy. Here one can see the wall of the duodenum clearly. That will be also dissected away from the plane of dissection and mobilized medially. Now we have found an avascular plane here, and hence the duodenum is mobilized and dissected away medially. Then the next steps are further mobilization of the colon. Next steps are to identify the ureter, which is lateral to the gonadal vein. Here one can see the inferior vena cava, and that's the ureter with good peristalsis, and we make a window, and then we place another port for assistance, as well as retraction of the lower pole, which will add to our dissection. And we have dissected the lower pole now, and moving a bit by bit towards the hilum of the kidney. So from the knowledge of the CT scan, we know that the artery is lying posterior superior to the vein. Here you see a very small venule. Slightest of pressure can lead to tearing, and it looks very small, but when it starts bleeding, it's horrible. So the inferior angle of the vein does not have any pulsations, which confirms the findings of the CT. I'm saying this because with the retraction and changing positions of the kidney, the artery can go a little superior or inferior, leading to the change in the original position. So the artery is posterior superior, and it is having inflammatory lymphatic reaction, so it has to be separate from the vein. The vein seems to be really short, so we are worried about how we'll apply clips on the vein. So dissection around the artery before clipping the vein is a must, so that if we can apply a simple and a single clip on the artery, the diameter of the vein will automatically become smaller and clips can be applied easily. As I mentioned earlier, that this small venule looks to be small, seems to be small, but when it starts bleeding, it becomes horrible. So in order to control this vein, we need to take control of the artery, and to take control of the artery, we need to dissect it properly and dissect it away from the vein, so that when we are applying a clip to the artery, we must not catch the wall of the vein, or we must not perforate or injure the wall of the vein. As it is directly connected here on this side to the inferior vena cava, pressure in this vein and the volume of blood will be more, so that can lead to torrential bleeding. So there are a few new things in this video. One was the adhesions of the colon to the liver, and the second thing is about to come, and then we will do some maneuvers in order to overcome those difficulties. So dissection of the artery is completed nicely. It's a big artery, so once we are able to clip it, the vein is going to be collapsing expectedly. You can see that the pressure in the vein is minimum now. Okay, now while applying the clip, what happened, that the hook of the clip got caught in the posterior surface of the vein, leading to a small hole but a big bleed. We try to hold it with our bipolar forceps, but the prongs are very short, so we need to have a grasper with longer prongs, so that it can cover the whole wall, and then a quick suction of the field so as to make the vision better and to see the structures better. And also, in the meanwhile, while sucking all this blood and clots, we need to think, what is our plan? So what we have done here is that, and again the same problem, what we have done here is now that we have increased the pneumoperitoneum from 12 to 14. We have placed another 10 millimeter port through which we can suck this clot at the same time while dissecting. We can also, I think in this case, the angle of the clip applicator was not appropriate. That's why it caused this dislodgement of the clip from the applicator, and this led to all these events. So I placed another 10 millimeter port so that the clip can be applied directly over the vein while we are keeping the vein in the grasper. Now you can see that the side of the vein towards the major vessel is secure. Now the things are in control. So increasing the pressure, number one. Number two, holding the injured vein with a non-traumatic forceps for a while. And then of course placing another 5 or 10 millimeter port has led to a success in dealing with all these difficulties. And after that the procedure ended within 10 minutes. So the vein is now complete and we have divided it. The side towards the major vessel is secure. And now we are further applying another clip on the artery, as this is a big artery and it's better to place another clip while we have the chance. And then we divide this artery, and then the rest of the procedure is done as a routine removal of the kidney. After removal of the kidney and cleaning of the cavity, you can see the pedicle nicely. Thank you very much for watching.